So I'll be speaking on Aqueous biomarkers in diabetic retinopathy. We all know that in the normal retina, the retina is partitioned from the systemic circulation by the blood retinal and the blood aqueous barriers, but yet it receives its nutritional supply from the retinal and choroidal circulations. So there is bound to be some area of interface. We all know about this, how endothelial cell damage causes breakdown of the inner blood retinal barrier, and how hard exudates, edema comes, how pericytes lost can cause microaneurysms, and then they will leak, and how ischemia will form neovascularization. So this is a brief overview here. So growth factors, hypertension, hyperlipidemia, hormones, hyperglycemia, these will actually move into a lot of these pathways, PKC, polyol, age, oxidative stress. There will be a lot of oxygen-free radicals, which will cause apoptosis on the one side and inflammation on the other side, both of which will finally cause ischemia and neovascular damage. So this is a typical diabetic macular edema with fluid here, hard exudates here, the pericyte loss leading on to microaneurysms, damaged capillary, etc. So the first thing that will happen is when hyperglycemia occurs, there's going to be advanced glycation end products, and one of the common age project is what is called CML, carboxymethyl lysine, and then pentosodine. These two accumulation inside the neurons, glia, and vascular cells are the first part of pathogenesis. And then, as early as in 2001, we know that VEGF and some non-CML and CML are there in a diabetic retinopathy. And another thing called galectin that will occur even in pre-ischemic stage prior to the angiogenic state. This we knew in 2001, and then only the work on VEGF had started. There are certain metabolites, but most of these metabolites work through NOS inhibitors, that is nitric oxide synthase inhibitors, which supply the reactive oxygen species. This is the basic pathogenesis and the oxidative stress. And then once this is also over, comes our factors that we know now, the inflammatory and the angiogenic markers. Angiogenic markers are basically, VEGF is the most common marker. There are a host of other markers in which these are all involved in diabetic retinopathy. Many studies have shown that some increase, some decrease, and different studies have shown differently about this. Now we did a small study looking at the VEGF levels in the Aqueous after each injection of ranibizumab to differentiate between responders from non-responders of anti-VEGF treatment and correlate the changes in VEGF over 6 months to vision improvement and CMT improvement over a 6-month period. So 6/9 vision or more than 300, 6/9 or less, more than 300 microns edema were taken. 3 injections were given for all, and then PRN if central macular thickness was more than 300. Each visit, logmar vision and OCT were also taken, and each time we gave intravitreal injection, we took an aqueous VEGF levels. 40 patients were involved, and we divided them based on visual acuity, like 0.3 till 0.3 logmar. Based on visual acuity, based on baseline CMT, and based on baseline VEGF, we divided, and we'll look at how each group fared. Now this is based on baseline vision. You can see that this is the a poor vision group. Even the poor vision group, this is logmar visual acuity. That's why this is poor vision. Even the poor vision group improved by about 3 lines. Okay, the better vision group obviously did not improve like that because 6/9, 6/12 cannot improve more than 1 line. So what has happened to the CMT? You can see that the poor vision group, actually by the end of the 3rd month, actually the central macular thickness reduced to more than that of the other groups. Why? Because there is an element of macular atrophy. Now what has happened to the VEGF in this? Understandably, the poor vision group actually had highest VEGF, and this better vision group had lower VEGF. But you can see that over a period of time, this VEGF increased at about 4 months. So what about CMT? In CMT, it's like the higher CMT, yes, higher VEGF. And higher CMT had poorer vision. The vision has improved, the central macular thickness has reduced, but VEGF, as you can see, by the 4th month, gave a surge in that group also. Now this is more interesting. We categorize the baseline VEGF into more than 2000, like that. And higher VEGF always had difficulty because 4th month there is always a resurge whenever we stop the injections. And the best response was not seen in the 500, the least VEGF activity, but in the intermediary groups, which told us that there is a group with poor visual acuity with low VEGF levels, which are the groups in which cytokines may play a result. Now, based on edema, I think I'll stop here. Thank you.
What is the conclusion of the study?
The conclusion of the study is that VEGF is significantly, there is a group of patients in whom VEGF is not mediating the diabetic macular edema or its course. And that group we have not differentiated till now. And if we differentiate that group early enough, then we need not give 5 or 6 or 7 injections to decide whether we need to retreat them with some other treatment. We can initially change them to a steroid or something like that. So there is a definite group like that.
Those who have got a low anti-VEGF levels.
Low VEGF levels.
Low VEGF levels.
Low VEGF levels. In those patients, we have actually checked the cytokines, and I am analyzing those results.
Thank you.
Thank you.